Welcome to Start PT Now podcast to let you know what's going on in your world and my world. Your guy, my guy, right guy.
We're joined today by Dr. Nathan Yokel of Regenerative Orthopedics and Sports Medicine. Serving the North Bethesda, DC, and Columbia areas, Dr. Yokel has a very deep, wide base of knowledge, understanding, and expertise in this field, and we're really excited to pick his brain a little bit and learn more about what he does.
Thanks for having me, guys. Looking forward to it.
Thank you for being here. Now, I'm going to jump into this right away because I think there's a big term used in the medical world that most people may not understand. And if you can give us a little bit of insight, what is physical medicine?
Sure. So physical medicine and rehabilitation, or physiatry, is the subspecialty of medicine doing things pertaining to the body and how to heal it. So you can be a physiatrist and help people that have a stroke recover. You could be a physiatrist and help people that have a brain injury and recover. My subspecialty could also be considered like non-operative orthopedics. I'm dealing with all various degrees of musculoskeletal medicine, whether it be tendon, bone, ligament, nerve injuries, and trying to help people recover from them and get back to life. It's really a focus of how the body functions and helping to restore that function. And we are all non-operative professionals, all non-surgical professionals. Orthopedics is the one field that is kind of flipped on its head. If you were to have chest pain, you don't go to see a cardiothoracic surgeon. You go to see your doctor, a cardiologist, and you kind of work your way up. And yet, if you sprain your ankle, you go right to the ankle surgeon. The way that it should work is the pyramid should be flipped. If you sprain your ankle, you should go see a physical therapist. If they think no problem, they can handle it, great. If they're concerned that there's something else, they would send you to me. I can do ultrasound in the office, examine it. I can order an MRI if needed. And if I think you need surgery, if you should consider it, then I would send you to the surgeon. But the way that the structure is in the United States, it's a little bit backwards. And it's sad, but a lot of people don't know what a physiatrist is. They hear, they think podiatrist, like a foot, psychiatrist, like your brain, physiatrist.
It's almost like in our world where people confuse physical therapy for chiropractic care or massage services as part of the physical therapy world is the one thing we're supposed to do. Now, it seems like education to the masses is needed here, especially for physical medicine. What are some of the things as far as in your world that you see patients can benefit more from in the physical medicine space?
I think that absolutely education is one of my missions and goals, to spread the word about what we can do and what our options are. I think that one of our key tenets is getting a very specific diagnosis. And we're not just diagnosing what is generating your pain, but what led to the injury that led to the pain generator? What is the weakness pattern that leads to this problem? Sure, sometimes you have an injury where you get tackled or you fall. A lot of times you're like, I don't know, I was doing this, and then, over the last few months, I started getting this nagging pain. And a lot of time the pain generator is due to a functional weakness in other areas. So we pride ourselves on taking a very holistic approach, really taking a long, detailed history and doing a physical examination to better clarify what the process is. And then we're using a lot of musculoskeletal ultrasound, which is using an ultrasound to look inside the body, look at the tendons, look at the ligaments, look at the joint and the nerves, and clarify what that injury is, both to better diagnose the problem, to more accurately guide our injections or treatments into that area, and also to educate the patient and show them what's going on in that moment, in that initial evaluation in the office, rather than go get an MRI and come see me in a few weeks. Not that we don't use MRIs for some things, but musculoskeletal ultrasound really is the stethoscope of my particular field.
Absolutely. And I know you've studied in Pennsylvania, locally in Georgetown, and you have a pretty diverse educational background that includes like medicine, public health, and even business administration. I was wondering, with a diverse background like that, how has that sort of shaped your approach to patient care?
Sure. Well, I guess going way back, my mom is a physical therapist. So growing up as a kid, she would bring me to the office and I would be kind of sitting in the waiting room playing with patients. She's a pediatric physical therapist, so dealt with a lot of kids with developmental differences and other progressive problems. And so from a young age, I was kind of exposed to the idea of wanting to help and heal people and kind of get them back into life. When I went to medical school, I used to scribe in an emergency room when I was in college, and that allowed me to kind of gain some different perspective there. I went to medical school thinking I was going to be an ER doctor, but decided that's not how I wanted to live my life in the long run. Wanted to have an office. I want to have a long-lasting relationship with patients. I was thinking about doing orthopedics and being a sports medicine doctor, but at some point During medical school, I have injured my finger several times. I just injured it again playing football. This is something different. But so these have been through the ringer over the years. And I had my first son during medical school. And so I wanted to be able to spend time with him while he's growing up, not necessarily be stuck in the office doing 80-hour-a-week residencies and kind of not being able to see him. So all those kind of led me to this field of physiatry. Within the field, I was very drawn to doing procedures and the idea of marrying technology with medicine. I wanted to be on the cutting edge. And so using ultrasound to diagnose these injuries, I think is very progressive in the wave of the future. Using regenerative reparative medicine to help utilize the body's own healing capabilities to better heal itself, and the progressive developments and discoveries and treatments that are coming out of that, I think we're only at the cusp of it, but we're seeing more and more evidence showing the value of these procedures. And that's very exciting to me. So I've crafted the rest of my career at continuing to hone these skills and gain that knowledge.
And that's super interesting. I know sort of that we were getting into the ultrasound and sort of how that is almost pushing the field forward. It's kind of altering the way that people are approaching this sort of aspect of care. I did want to ask you if you could maybe elaborate a little on some of your research regarding the accuracy of ultrasound guided injections and sort of like how it's
Sure.
influenced your clinical practice.
Sure. So, I mean, I think one of the drawbacks holding ultrasound back and why it hasn't become even more of a ubiquitous tool is the user error or user operated. Like you can get one person ultrasound, another person, they can have two different degrees of level of training and accuracy. And so I think that is a drawback in general. When I was in residency, we did a study looking at the efficacy or the effectiveness of doing an ultrasound guided sacroiliac joint injection, which is where your spine meets your pelvis, versus doing fluoroscopic guided injection, where we injected some dye under ultrasound and then looked at it under fluoroscopic and see if it was in the SI joint. And it's very accurate, and yet still there's a slow responsiveness from insurance to cover some of these things at times. Using ultrasound is very dynamic. I can see things moving. I can see blood flowing. I can see where blood's not flowing. I can see where things are impinging. I can look not just at a meniscus or tendon, I can look at the fascia or the muscles that are injured or not moving correctly, and I can show the patient, and I can show them over time how it improves or how it doesn't improve, and I can use it to guide that needle right into the area to make sure our treatments are accurate. The accuracy of ultrasound-guided injections is much better than doing a blind, quote-unquote, injection, which is an injection without using guidance. The accuracy of using ultrasound for soft tissue structures rather than fluoroscopic guidance, which is using it for spaces where bony landmarks, again, just more accurate. You can make sure you're not going through nerves, vessels, whatever it might be. We use ultrasound to guide procedures such as regular joint and tendon injections. We also do it to design percutaneous debridements, where I'm using a needle to kind of chip away and smooth out a little bone spur in a knee or in a toe. We use it to go right up next to a nerve, but not in it, and put a layer of fluid around the nerve to free it up or hydrodissect it. And I can use it to loosen up scar tissue. And all those procedures that I just prescribed are covered by insurance. I think there is a misunderstanding that a lot of the things that I do are not covered by insurance, when the diagnostics, the ultrasound guided procedures, all those are covered by insurance. It's only the regenerative or reparative medicine, which we'll talk about in a bit, that is unfortunately not covered by insurance yet. I think it's only a matter of time before things catch up, but it's based on the cutting edge nature of what we do and the structure of the system, which is both aided but hamstrung by the FDA and some of their guidelines.
What's the most common injury that would benefit from this procedure that you offer there?
So, I mean, that was a gambit of procedures that can be used for various different injuries. I think unless you have a fracture that just needs to heal, you need an orthopedist to put that fracture together. And that's not something that we do. Now, if you have a fracture that's in place and not healing, there are things we can do that can speed up the healing or that can promote a bone that is not healed to heal itself. If you have a meniscus injury that is torn and flapping around, that needs to be sewed in, or if it's getting caught up, it needs to be cut out. If you have a tendon injury that is out here and needs to be put together, those are surgical concerns. Literally anything else, I think we can address with some of the treatments that we do.
And I know having these resources and that level of technology is not only, I'm sure, very helpful for you guys and what you do, but also for from a PT perspective. I know the collaboration, we've even had our doctor, Dr. Stacy come in and sort of shadow and sort of see some of the things that are going on there and, just express optimism sort of about the program and sort of the effectivity of it. Also help
Collaboration that
him.
we've had with your team with other therapists I think is invaluable. And I think patients really appreciate the idea that I'm actually in communication with the therapist. Like, I want to tell them what's going and give them my best plan. I also want to hear from them if something's not coming along or if they think there's something else in the plan I should consider. And I think having that back and forth, having that open dialogue, patients really appreciate it, and it leads to higher effectiveness of quality of care.
Yeah, and it also leads to, both parties, the physical therapists, to do their job even more effectively, especially if the plan of care is being met by what you want done for your patient.
Sure, because I'm not just asking them to work on the knee. To fix the knee, you have to work on the foot, the hip, the back. It all comes together, which is the way that therapists are generally attacking these problems in general. So for the patient to hear it on both sides, for us to have this open communication and kind of a check and balance is very helpful in promoting good, consistent progress and being able to pick up a patient that's not coming along. If I have a patient that's not coming along and can't participate in therapy, I don't want them to wait 6 weeks for their follow-up. I want them coming back sooner. And that's where that trust level is very effective. And for somebody like Jonathan or some of your other therapists to come in, kind of spend time with me, they also have a better idea of what I'm doing, how I'm talking to patients, what these procedures look like, so they can better educate their patients or be a source of information for them.
With all those different tools and resources that you have, having, the PTs come in person and seeing that in action, are there any specific aspects of the diagnostic tools, maybe like the ultrasound, for example, that you find to be the most helpful for PTs or that you share with them the most?
Ultrasound is cool, and they like to see what's going on. And I even have some therapists that have started using ultrasound in their practice for biofeedback to kind of show somebody if that muscle is contracting or not, or to guide some of their dry needling. But I think some of the things that I do with my physical exam is a little bit unique, where I'm looking at how function is affecting other areas, where I'm checking a shoulder, but I'm facilitating other areas to show the patient the change in that strength. I think for therapists, it also can be eye-opening to see kind of that complete approach and to have a better understanding of what I'm asking for them when they're working with some patients with a shoulder injury. We're really working on back core stability rather than arm strengthening, where we have a patient with knee where I really need more core pelvic quad strengthening, not just knee stuff. And I think it really helps tie us together as far as having a unity and a cohesiveness with how we are both treating and educating patients.
It absolutely is. And I want to get back to the regenerative portion of
We
some
might
of the
need a whole
treatment.
nother round too for regenerative stuff, because that
Oh,
was
we will, but I wanted to jump into PRP therapy.
Sure.
And first of all, your thoughts on that, and more importantly, I was touching on when Kobe Bryant received his PRP treatments after his knee surgery, and he came back to the court almost in half the time.
Absolutely. I think when we're speaking about regenerative medicine, the plasma-rich and growth factors or the platelet-rich plasma you're speaking about is just one of many options. The whole idea of these regenerative procedures is to stimulate inflammation and blood flow. When you have an injury, your body goes through the phases of healing, sore and inflamed for a couple days, fast phase of healing for like 3 to 4 weeks, slow remodeling phase of healing for 6 to 12 months. Then things are kind of stagnant. Your body's like, we did what we did. We're going to use other things around it. We develop these compensation patterns. Most traditional orthopedic medicine is calming things down. Advil, Aleve, cortisone. We're calming it down so it feels better, but we're not fixing anything. But the idea is you calm it down, you get things stronger. By the time it wears off, things are better. And to put out a fire is something we can do at any point, but most people want to fix the problem. When you have an injury that's been going on for a while, or if you want to speed up the healing of an injury, like Kobe, we want to do something to stimulate inflammation and blood flow. These other things decrease inflammation. So if we can do something to stimulate that process, we can promote faster healing, or we can re-spark healing in something that is stagnant. So these treatments range from EPAT or shockwave. This is a post-energy treatment where we're using what looks like a thumper massage gun to stimulate blood flow by using post-energy waves. This can be very helpful for tendon and ligament inflammation, irritation. This can be helpful to stimulate blood flow to a non-healing fracture. This can be very helpful for more mild things like that, even frozen shoulder, when a lot of it is myofascial, but not going to be effective for larger tears or injuries. And there's a huge amount of evidence and research in the podiatry world where they've been using it for years in plantar fasciitis and Achilles tendonitis, but more and more growing support for other body parts, to the point where most pro sports teams have an EPAT or shockwave machine because you can do it in season. You could do that treatment, then go play that day. And so that is something that we offer. On from that will be something called proliferative therapy or prolotherapy, which is basically for us a dextrose solution where your body sees that dextrose as an irritant. It also osmotically is drawing the growth factors to that area to stimulate a healing reaction. Now, this one's going to require a couple days of taking it easy and about a week before more strenuous activity. But it is something we can do in season here and there if an athlete can take a few days off, especially if they're injured anyways. And it can be very helpful with level 1 evidence for very mild arthritis. It can be helpful for low-grade ligament and tendon injury, tendonitis. It's not as effective for stronger meniscus, labral, bigger tendon injuries, moderate arthritis, for those who are using something stronger. On from that would be the plasma treatment. Platelet-rich plasma, plasma-rich in growth factors. That's where we take your blood, centrifuge it, throw away the red blood cells that deliver oxygen. And then we centrifuge it again, throw away the white blood cells that are fighting disease. We're left with these growth factors involved in healing. Now you inject it back in there, it's going to stimulate a much stronger healing reaction. Now you got to take it easy afterwards. You got to minimize pressure on the areas. So we're usually using a sling or crutches to take pressure off just for a few days. You're out of that, but you're still minimizing more strenuous stuff for more like a few weeks before you get back to that full activity level. But again, you're walking around normally by a week. By 2 weeks, you're biking, elliptical, swimming. You're just maybe not running and jumping for about a month. And so that is something that's more of an off-season treatment. But it can be very effective for meniscal degenerative tears or meniscal tearing, mild rotator cuff tears, great evidence for elbow tendinopathy, tendinous elbow, golfer's elbow, Achilles tendinopathy, patellar tendonitis, gluteal tendonitis. These are all treatments that have randomized control studies behind them. There have been about, going back to July, 144 randomized control studies of plasma treatments for musculoskeletal injuries over the last 20, 25 years, 127 of those showing a positive effect. The ones that weren't effective were not using high-quality plasma, at least half of those, where they weren't using a high enough concentration to get a potent effect. And so these are randomized control studies showing this evidence, and yet again, still seeing a lack of support from insurance coverage. The treatment can be augmented when you're dealing with a bone injury or when you're dealing with arthritis by spinning the needle into the bone and doing an intraosseous treatment to feed the cartilage from the inside out. And a lot of times when patients have these procedures, there's growing popularity, but also means there's a lot of people not doing it the right way. I very rarely will just put some in the knee joint. I'm treating the knee, I'm treating the meniscus, I'm treating all these areas around it, again, with that ultrasound guidance to get a more potent effect. On from that would be the strongest treatments we have, cellular treatments, using bone marrow, using adipose. These are treatments that are rich in stem or signaling cells. We're not saying a stem cell treatment because it's not just those cells, it's other things around them, but they're commonly referred to that by people. This is using your concentrated bone marrow or taking your adipose, cleaning it, washing it, reshaping it, and injecting into these areas. This can have a much stronger reaction. This can cause a huge healing reaction. And in the case of the adipose, your body will also use that as a scaffolding to kind of stabilize these areas. This can be effective in more moderate to severe arthritis. This can be effective for larger tendon ligament injuries. This can be effective for larger meniscus injuries or labral tears. I could also use it for all those other things we talked about, although maybe overkill as a starting point. But there's a varying degree, as you can see, of invasiveness, potency, and cost that we're trying to balance the patient and give them the options. Look, this is the biggest gun, but for you, I think this might work. Look, we can try this. If it works, great. If not, we're doing this, and kind of on from there. And so we're kind of trying to make an individualized treatment plan for each patient. Now, the same treatment that Kobe went to Europe to get 20, 25 years ago, we're doing here in Maryland, D.C., Bethesda, and we have been for years. And so we just got to get that word out about it. Although they're not covered by insurance, these procedures, you can use your health savings and flex savings on them. And so many patients are taking advantage of that, especially this time of year.
Well, more importantly, if you can't walk or do much, what good is it to have money to save up to do nothing
Absolutely.
with?
And I mean, I think everything is a choice, right? I'm telling patients when I'm doing these procedures, if I think they can see a surgeon or not. Again, sometimes just to do your due diligence and know what's out there, sometimes I'm telling you can see them, but this is going to be a better option for you. Everybody has to take their own path. I would encourage everyone just to get a second opinion on anything before you move forward with a life-changing experience.
But you're right, the science has caught up with medicine. We're here at a new stage in a new era where technology is, now biotech is where it's at next. And it sounds like you're ahead of the game there. And thank you again for joining us, Dr. Yokel from Regenerative Orthopedic Sports Medicine.
One thing about the rest of those treatments that you touched on, which are now limited by FDA guidelines, things like exosomes, things like amniotic fluids, things like umbilical cord cells. We were doing those treatments for years before recent FDA guidelines said that we shouldn't be doing them. I think they'll be back in the coming years. I think it's more of a FDA regulation rather than a safety or efficacy issue, but they are not true cellular treatments. They have not been shown to be effective as these other treatments. And a lot of times, currently, unfortunately, they're administered by chiropractors or less scrupulous providers because people that are following the letter of the law are not doing them right now. One day they'll be back.
And there's so much great information that you shared with us today, especially like you said at the start of it, the regenerative sort of side of things.
I have so many questions.
Could be a whole episode on its own. So we definitely would love to get you on the calendar, get you back in here sometime.
I'll be
to
back,
dive
and I'd
some
love
more
to connect
into
some of
it.
my other doctors to do some episodes
Yeah.
with some of your therapists discussing our different strategies for treating specific injuries, right? That, how we treat shoulders, knees, whatever. I think that's something that will be a good resource for patients.
Especially neurological issues, especially with the student athlete. I imagine that you see a lot of them. And
We
it
do.
seems like within 30 days, these guys are up and running again.
Absolutely.
If you're Kobe Bryant years ago, you have to go to Europe to try to get
Right.
done, and people are calling it, it's almost absurd to some people. They can't imagine how it's even possible to do that. And then now we got
the
it
future is
right
now.
here in our own neighborhood here in the DC area by some fantastic professionals like yourself. And we just want to thank again Dr. Nathan Yokel of Regenerative Orthopedics and Sports Medicine for joining us and sharing this information.